Thank you all very much for joining us for another episode of Scientifically Speaking. We are going to be discussing tough topics in laser surgery and skin surgery with some of the foremost panel in the world. We have Dr. Chris Zachary, who's been chairman of dermatology at UC Irvine for many years and a well-known Mohs and laser surgeon. We have Dr. Suzanne Kilmer from Sacramento, who's really been a pioneer in many of the laser procedures that we do. Dr. Biesman from Nashville is a oculoplastic surgeon and laser surgeon, and Dr. Matt Avram from Harvard is the director of the cosmetic and laser department there at Harvard, and he trained in dermatologic surgery, laser surgery, but he's also an attorney. So thank you very much for joining us. In tradition to this segment, we have everybody wear a hat. I'm wearing the Professional Bill Writers Association hat because this happens to be the week where typically in Colorado we have what's called the Stock Show. It's the largest show of its kind in terms of people doing rodeo and selling farm equipment, and my kids driving John Deere tractors. And with the COVID pandemic, we're not having that this year. And it's tough because we're used to seeing a bunch of events that night. So Brian, tell us about your hat and about yourself.
Well, for those of you who can see, everyone can, the maize and blue, from Michigan, went to Michigan undergrad, went to Michigan for medical school. And although we have 3 kids, none of whom went to Michigan, but our son is a huge Michigan fan. We make a tradition of going to at least one road game a year. The hat that I'm wearing, we got when Michigan played in the Sugar Bowl last down in New Orleans. So I try to get a hat every time he and I go to a game together, and this is our most recent.
Very nice. We're a big Michigan family ourselves. And 2 years ago, we had what I call a trifecta. In the same day, we did a Michigan football game, a Michigan hockey game, and a trip to Zingerman's Deli.
Woo-hoo. There you go.
So Chris, you spent a lot of time in different institutions, and some part was at University of Michigan, but tell us, you've been at UCI and you're wearing a UCI hat.
This is my hat, my design. Yes, indeed. You can tell I'm British, I speak with a funny accent and I've got crooked teeth. And yeah, I've worked all over Ann Arbor, St. Louis, Minneapolis, San Francisco, but I love living in Irvine. And I've been so lucky to have worked with not only these colleagues here tonight, but some wonderful people. It's a great privilege to be able to work with you all, and I love doing what I do. Thank you very much.
Susie, what about you?
Well, I'm in Sacramento, Susie Kilmer, and I have a hat that says Republic of Rock because this is the only hat that fits my tiny head. I literally have a child-sized head, and my son worked at Republic Records, and he said this because he also had a little head, and he gave it to me, so it's a good remembrance.
And then Matt.
This is a Brooklyn Nets hat. I'm from Brooklyn, New York. In New York, I failed as a professional actor. I gave up being a professional lawyer, but I'm one of 5 dermatologists that grew up in the city, and I am now in Boston, Massachusetts, as a cosmetic and laser dermatologist.
I want to start out with a topic that has garnered some attention recently. From a perspective of dermatologic surgery, I do Mohs surgery, I do laser surgery, I do fillers, and we all prep the skin before we take care of a patient. People's preparations differ. And I'm a member of Dr. Zachary's department at UC Irvine, and together with Dr. Zachary and Melissa Shive, as well as Jason Rivers, who was with us at a meeting, we published recently an article about Chlorhexidine Prep in the journal Dermatologic Surgery. And in many cases, it's the best we have. But there's been some discussion about this over the years, and in the oculoplastics field and the facial plastics field, there has been some hesitancy to use chlorhexidine. So I want to turn to Dr. Zachary to talk about really his way of prepping the skin in terms of Mohs surgery and the fillers that are done in the department. And then we'll talk to Dr. Brian Biesman, who as an oculoplastic surgeon can really educate us on really some of the issues in the keratitis. And he wrote really a glowing editorial covering the topic as well in Derm Surge. So Chris.
Thank you, Joel. Yeah, I think it's a big issue. It wasn't so long ago, maybe 18 months ago, and there were a number of articles which were really critical of using chlorhexidine on the head and neck, and I understand the concerns there, but I would just tell you at the same time that I banned the use of acetone in the clinic years ago when I was up in Minnesota at the VA hospital, when my fellow was doing a chemical peel on a patient, and I was standing probably 50 yards away doing some charting, and she had used acetone, and I heard this whoosh noise, and there was only one thing that does that, which you can hear at 50 yards, and that is the sound of oxygen going into a room which has been set ablaze with an acetone fire. And I ran into the room, and the patient's head was on fire. My fellow at the time, her head and hair was all on fire. The flames were predominantly down below, but the story was that this patient had a biopsy before the chemical peel, and after the chemical peel, the fellow noticed that the biopsy site was oozing a little bit. So she picked up the hyfricator, pressed the button, and whoosh. So because of the low flash point of acetone, it really is incredibly dangerous, though we don't often see it. But we had a death up at UCLA about 4 or 5 years ago in a laboratory there with an agent that had a very low flash point. So anyway, getting back to the story here, because I don't use acetone, Johann Peikart and I in 1987 talked about the use of Hippo Cleanse instead of acetone for washing the face, and we found that it was absolutely just as good as acetone and very much safer. So the study that we looked at, really, we reviewed the literature and found that there were indeed cases of severe eye injury and ototoxicity, but they were only in cases where the patients had been under a general anesthetic. You know, if you're wide awake and you have Hippo Cleanse in your eye, you will know about it and you'll complain about it, and the staff will immediately wash it out. So do I use Hippo Cleanse on the face and around the ear and eyes the whole time? But I'm careful. Once I put it on, I'll wipe it off, and I'll be very careful. I do it. I'll be very careful. Just because you wipe it off doesn't mean to say that it's not working. It's still there at a very minute amount, but you're not going to get a drip that goes in the eye or down the external auditory canal. I mean, you suggested Brian might be able to add something there, so I'd really appreciate his take on that.
Chris, I certainly don't have any objection to using this product on the face, but your point is 100% correct. You just got to be careful. You can't get it in the eye. Right. If you get it in the eyes, you need to irrigate copiously and immediately. You also pointed out something really important, which is the general anesthesia cases where this leads to ocular problems. What tends to happen is corneoscleral protective lenses sometimes are liquid sterilized, and they'll use chlorhexidine as a sterilization agent. They won't rinse the lenses well, put them in the eyes, and then they'll do an 8 or 10 hour case. And you take the lenses out and people have corneal blindness. If you were to in a contact lens and put it out over the eye, yeah, it's going to be a problem. Yeah. Using it cautiously, if you're using it on little individual wipes, or if you're going to use a sponge, make sure it's not sopping wet and dripping. Yeah, I think it's fine. You just, like you said, be careful and have appropriate irrigation available.
So in the article we reviewed, there was a dermatologic surgery article from January 2015 where it showed about 78% of derm surgeons use chlorhexidine on the face, but when it comes to around the eye specifically, that number goes down to 18%. There's some well-known derm surgeons who do use it around the eyes, including Gary Monheit, who does that at the Ophthalmic Hospital in Birmingham, Alabama. So I just, Dr. Kilmer, your experience using chlorhexidine to prep before fillers, what do you do before laser procedures? And then Avram, from a perspective of, the medical legal aspects of this, we know in the literature that there are studies showing that chlorhexidine has the lowest rate of infections. It was a 20,000 Mohs compiled study that was done that I went back with some other folks, Mirat Alam and Daniel Schlesinger, to look at the infection rate, and chlorhexidine was lowest. So there's a lot of evidence that, they're to use it. So if you're using it and you do get it in the eye, we'll talk a little bit about, from a medical legal perspective, beyond what Brian advised in terms of flushing. So Susie, what do you do?
Well, I don't do Mohs. We were doing chlorhexidine, and now we've actually changed over to, I don't know if I'm allowed to say the trade name, but it's Lasersin, which is hypochlorous acid. And it's actually antibacterial, antiviral, antifungal, anti-inflammatory. You can spray it right in the eye. It doesn't hurt at all, other than it startles somebody. And we were doing it regularly because of, for laser procedures, especially fraxal neck and chest, where we tended to get a little bit more infections. And now we've sort of used it for our filler cases. And when we first came back after COVID, it sort of gave us an extra, sense of safety, because you can literally spray it up the nostril, spray it around the mouth, spray it around the eyes. So for when you are doing those procedures, I think it's been great. And our infection rate for lasers now, because again, I'm not talking about Mohs per se, has really plummeted, especially the main area. Not that we had a ton, but it was typically the chest, which tend to get infected. And so when I do fully ablative, like, as you guys know, we all love to do, we do more aggressive procedures. We send them home now with hypochlorous acid and have them do their typical vinegar soaks. And then 2 to 3 times a day, they also spray with hypochlorous acid.
So I've been using hypochlorous acid for about 4 or 5 years. I've written a bit about it. We use it for fillers around the eyes. We use it for Mohs around the eyes. And honestly, patients really like it because it is a bit soothing. If you keep it in the refrigerator and you spray it on, it's totally eye safe. I give every resurfacing patient, from hybrid fractional like Halo to ablative fractional to full field ablative, a bottle of hypochlorous acid, which is the same Lasersin that you use, and I have them take it home. There's something still about Mohs where I use betadine around the eyes. I think Technicare, sometimes is a little bit difficult to control as opposed to the foam of chlorhexidine. And if it gets in the eye, it can still sting. It's supposed to be safe, and Technicare is Chlorhexidine, and it's come on the market and come off the market several times. So we tend to use a lot of hypochlorous acid, and I agree with you. Matt, what do you do at Harvard? And just take us through some of the legal implications, because we do know that in the literature is the keratitis type of issue. So if somebody is prepping and it's not around the eyes, but let's say they use the Mayo stand, they dip into the prep and they're walking over the patient, and they getting to the forehead, they drip some in the eye. What are the legal implications of that?
Yeah, so first of all, we use chlorhexidine in our practice. With the laser cases, I've got to say, we tend to use less of the topical antibiotics or pre and post-op. It sounds like we are less aggressive with that than the rest of the group here. In terms of this, what really matters is what the standard of care is and what's foreseeable and what isn't. The fact that Brian wrote something in derm surgery is very helpful. And the fact that dermatologic surgeons are doing this to the high rates that they are sets it as, I believe, a standard of care. So I don't think there's anything negligent per se. And I think before these things in the literature, there might have been an argument to make that. That's done. Now, if someone spills something or something like that happens, then you have to get into whether or not there was malpractice in some way, that someone was doing something that was below the standard of care. And you do have to some degree to be careful about it getting into the wrong place. Accidents can happen, but you need to be aware of that and protect against that. So the short answer is you have to look at what the standard of care is and what the facts of the case are. It really depends on how something like this happens. If someone trips, but it was, the Mayo stand was right near the face, that's a problem. If it flies across the room, it's not great, but that's less of a problem. It really depends how proximate the cause was and whether or not there was something negligent that happened. But the chlorhexidine alone, if you get a keratitis or if you have ear issues, is more an issue of whether or not something was done inappropriately, not the fact that you used it alone.
Joel, can I just add something there? Because, we all assume then when we're giving a bottle of something that it actually has in it the appropriate material, right concentration. But there were two instances I just want to mention. One was a colleague of ours up in South Bend in Oregon who was doing a chemical peel on a patient, a young lady, a nurse actually, and he caused very significant scarring. He was using TCA 25%. He used a two-hand technique on the back. As soon as he went down the back here, it went bright, solid white, and he realized there was a problem. So he stopped, right thing to do. And he had the TCA checked, and it was actually 125%. Okay. Now and in a lawsuit, he was actually found guilty, or he was found liable, I should say, but percent-wise. I think the company settled out of court. The other thing, if you remember, it was years ago when I worked with Roy Grecken at UCSF, we had a host of Pseudomonas infections. And I thought, oh God, our technique's pretty bad. But we actually looked at the bottle of Technicare, which is what we were using at the time, and there was Pseudomonas in the Technicare. Then we looked at the cupboard where we had all the Technicare bottles unopened. They all had Pseudomonas in it. That's one of the times when Technicare was taken off. I have no reason to believe that it is anything but a superb antiseptic right now. But we are always at danger of being, having to trust what we see. Where are we, Matt, in that regard? Can I ask you that? It's a big issue.
Something like that, where you get a batch like that, I don't think the physician's responsible, and kudos to you for finding that out. This happens in the laser world too. Sometimes the laser device, there is a built-in manufacturer's defect. And, one thing that's very important is to have a good relationship with your patient, because when these facts come out, if you do have a good relationship with your patient, I'm aware of a case where the patient and the laser surgeon had done nothing wrong. There was a defect that the physician couldn't have been aware of until after the case. The plaintiff didn't sue the physician because they felt the physician had done the right thing. I think there is, if you're using a standard filler, a standard botulinum toxin, or antiseptic, I think it's reasonable to assume that it's prepared in that way. Now, if you get 10 cases in a row where this is happening and you continue to do it, that might change things a little bit. But your duty of due diligence doesn't extend that far. Having said that, in the case of the colleague that you mentioned with the TCA peel, it sounds like what the physician did, everything was absolutely appropriate. It did exactly what you're supposed to do. Looked at the tissue interaction with the TCA and said, something's wrong here, stopped. But sometimes juries look at damages and they look at harm that happened to a patient more than they look at the actual factual circumstances, and look at insurance coverage and things like that. So as we all know, the legal system isn't always a fair one or based on law. Oftentimes it's based on the damage to the patient and the sympathy to the patient. So it gets very complicated, and nothing I would say tonight would be a bright line, because it is a fact-by-fact, case-by-case basis. Yeah.
Joel, can I bring up a little bit of a tangential safety issue that's not related to using prep solutions? It's slightly off topic, but exactly along the lines of what Chris just said. There have been two cases that I'm aware of where someone used an unlabeled syringe to give an injection of what they thought was local. In one case, and actually in both cases, it ended up being formalin that was in the OR being prepared for specimens. One case resulted in massive necrosis of skin on the face, and the other was injected intrathecally in a patient who ended up essentially brain dead. So unlabeled syringes are another thing to really be aware of, as long as we're on the topic of safety.
Deoxycholic acid looks like some of the sclerotherapy preparations that look like some of the, neurotoxins that looks
Botox,
like some
yeah.
of the anesthesia. Yeah, I mean, that actually is something that we have to be very well aware of. And sometimes people are preparing things and you inject it and someone mislabeled it. That's a really important point.
So there actually has been some issues with people using intralesional steroid. And if somebody prepares it early on and it sits on the counter and precipitates down, then if you're injecting it, for instance, in the nasal dorsum, it could go through the dorsal nasal artery, connect up with the ophthalmic to the central retinal. And there have been cases of amaurosis and visual loss and even permanent blindness related to intralesional steroid injections for that very reason. So we should really know what's in our needle, look at the bottles and know what's in the bottle. And when I'm doing chemical peels, I'm actually pouring the substance from the bottle into a metal shot glass myself. And I do that double check all the time. And when I'm drawing up intralesional steroid, I'm the one doing it. And I see if it's Kenalog 10 or Kenalog 40. So next topic is something that I've been thinking about for a long time. And I think everybody on this panel does a whole heck of a lot of laser resurfacing. And from a perspective of laser resurfacing, one of the things that I do a fair amount of is actinic cheilitis. So as a Mohs surgeon, I take care of a lot of squamous cells to the lip. And then after these patients heal up, I generally discuss with them ways to treat some of the actinic damage and that whitish hyperkeratotic skin on the lip where there's a blunting of the distinction between the mucosa and the skin. So when we're doing resurfacing, especially after someone's had a squamous cell, we have to think that some of this may actually have HPV particles. And when we're doing surgery and we're using electrocoagulation, for instance, a squamous cell of the lip, some of this may actually have HPV particles. And that's been studied when you look at the ultrastructural characteristics of those cells. So I've often wondered, to what extent is this really in the plume of the laser or plume in the electrocoagulation? So I suggested this to Dr. Zachary, and he got a fantastic resident, Sergei Cox, who wrote up this paper with us that was just published in Dermatologic Surgery. And I'm wondering, from a perspective, is this something that you guys think of? We advocate at the end of the article for people to get vaccinated against HPV. And I'll tell you my story of trying to get vaccinated. But Susie, can you talk to your experience? Is this something that you have thought about? Is this something that you have your staff members consider vaccination, or where are you with this?
Well, you probably don't even know this, but I did one of the first articles with simian immunodeficiency virus to see if that was in the plume way back when HPV was first being discovered, and it didn't grow out. So we figured that HIV was probably pretty safe, but HPV survives more easily. And I've always thought about it from day one. And as far as the vaccination, it's interesting. I haven't really thought to encourage them to do it, but I have thought about doing it. It's just hard to actually get it for people that aren't children. It's kind of crazy, but I do think it would be a really good thing to do. And especially because I do a lot of actinic cheilitis as well.
A number of things came from this, and one was of interest that the modern resident is very risk averse in this regard, apart from anything else. And so since that article, every single hyfricator in our clinic has a suction device, which I hate. It's very noisy. I don't know how well it works. But the younger residents are anxious to have this. The other aspect, just talking about treatment of actinic cheilitis, is when you use a CO2 or an Erbium-YAG laser, healing takes a long time. It's at least 2.5, 3 weeks, etc. It's quite uncomfortable. I've been using fractionated 1927 pretty aggressively, using like the Fitzpatrick's technique up to 75%. And the patients really heal, I would say, much more quickly, much less pain. But you've got to do it more often, probably 2 or 3 times. And then is it as effective? I don't know. I'd appreciate your opinions on that. But it's clear these days, particularly when we consider that, viruses are all around, we are inhaling them. the regular influenza A issues have been just non-existent this year because everybody's wearing masks. So clearly we need safety in the clinic. Everyone needs probably N95 masks, appropriate eye protection, and it's an issue. And I'm glad that our residents are driving this.
So Matt, from your perspective, we have the studies actually looked at HPV particles proximally in the air evacuator, distally in the tubing, in the reservoir and the filter, on the laser, and on different surfaces, as well as on the mask. And it's surprising that you do see this. And I agree with Chris. I think, we're probably better protected right now because we're wearing higher grade masks with KN95s. In some cases, people have access to N95s. Prior to that, I was just wearing the purple mask, which is a lower filtration, but not as good as the KN95. And I think I will, hopefully when this is all over, keep using the KN95 type mask for these resurfacing procedures, and maybe even double mask with the purple over it. But what do you think would be the way to advise people on this?
Well, I've been saying to my fellows and residents, we are wearing N95 masks in clinic. And when we do laser hair removal, I say, there's not a lot of good that's come out of this pandemic, but one of the things that's good is that wearing N95 masks, we're doing laser hair removal. Laser hair removal plumes, not so much on the infection front, but in terms of carcinogens and truly toxic compounds, it's protective of that. And that's also true, with what we're doing with hypercators and what we're doing with CO2. We actually, Yakira Levine and I looked at laser tattoo removal as well. That doesn't seem to have the plume issues, but we didn't look at the viral particles. I think we need to be very careful about this. And just, when we think about COVID, and this has nothing to do with COVID other than the principle of things that we didn't think about previously. Several years ago, we published a paper that showed that when you turn off the suction hose when you're doing laser hair removal, that 10 minutes later, the amounts of ultrafine particulate matter and plume in our waiting room, which is about 30 feet away and 2 closed doors away, is raised significantly just by it making its way down the hall. So there's a lot of stuff. It's great that you guys looked at HPV, and I think it's important that people do that. But I think the masking for our laser procedures alone, outside of the infectious issues, in terms of like COVID and influenza, things like that, I think just what's in the plumes in terms of the viral particles and the carcinogens and ultrafine particulate matter, that's all very relevant now. And I think that should be long-term.
So I just want to point out that according to the package insert, it is indicated for people to get HPV vaccine under age 45. I'm a little bit older than 45. After we went through this data, I decided I wanted to get the vaccine. And in the fall, I showed up at the pharmacy and the pharmacist said, I can't give it to you because you're over 45. And I said, wait, what if I write a prescription for myself and then you give it to me? My wife's a pediatrician. I take it home and so you physically give me the vaccine in a bag and I take it home and my wife administers it. And that's what we ended up having to do. So I also showed the pharmacist the paper and said, this is where I'm coming from. And it's not something that everybody keeps on hand, but you can find pharmacies that have it, ask them to order it. And Dr. Zachary, Dr. Cox, and I talked about having a survey just to see if we're able to change people's patterns. So I wonder how many people right now have been vaccinated against HPV. I've only had the first one, and I think there's 3. And then secondly, with this article coming to light and people talking about this on segments like this, perhaps, we can influence behavior and get people to look at this more specifically and change even some of those recommendations. I want to talk about eye protection. Brian, as an oculoplastic surgeon, you honestly are well-versed at the things that can happen. I think all of us, unfortunately, have seen ophthalmic injuries from different issues and different lasers and keyhole deformity and those types of things. We just did a review with one of Dr. Zachary's other star residents, Margit Juhatz, who really looked at ocular protection for laser procedures. It's part of a presentation for ASLMS. But I want to talk to you specifically about, you've written in Dermatologic Surgery an editorial about eye protection using, long pulse Nd:YAG. What are the things that you think of in terms of eye protection?
Big question. So let's break it down a little bit between the visible light and near infrared lasers, which are going to target pigment anywhere. The eye is full of pigment. Even light colored eyes have a retinal pigment epithelium posteriorly. The reason you develop a keyhole pupil is because pigment in the iris absorbs laser energy. So your light, typically your hair removal, vascular lasers, or your occasionally your near infrareds, 1064 being one, are lasers to be worried about from a standpoint of causing damage to the retina, the ciliary body, which is less common, or to the iris, which is what causes the iritis, iris injuries, atrophy to the iris with transillumination defects, keyhole pupil, or injury to the fovea. So the first thing that I would say is that even if you're working above the jawline, doing laser hair removal on the face, you need to have ocular protection over the eyes. You need to make sure that your ocular protection is well applied. So often I see ocular protection applied, and this is just in videos that you're seeing of colleagues. And so forth. They've got external goggles on, but it's not very tight, and one goggle is hanging down, the eyes partially exposed. The patient moves during the procedure or so forth. But you have to be extraordinarily careful that the light, one, doesn't get in the eye, and two, even if you're treating with a corneoscleral shell in place, and Brian Zellickson published this, Dick Ross published this 2 years ago, 1064 passes through an intact eyelid very effectively, and you can heat up a metal shield. You have to be aware of the fact that even if you have a shield in place, you can get transmission through an intact lid. That's the visible light near infrared lasers. The other class of lasers that we work about is the longer infrared lasers, the resurfacing devices, which also, of course, are devastating to the ocular surface because they're absorbed, of course, obviously by water. Their energy is absorbed by water. But Matt made a great point before. What if someone trips? What if someone inadvertently steps on the laser when they didn't mean to as they stand up to shift around the table? I've seen these, and people have asked me so many times if they're using 1550 or some other non-ablative wavelength, do I really need to use ocular shields if I'm treating the eyelid? Yeah, you do, 100%. And if you have an ocular injury and you don't have a shield in and you're treating the eye inside the orbit, I'll testify against you. It's just dumb.
So there have been circumstances, and not infrequently, and Dr. Zachary and I talked about one recently where we saw on Instagram somebody was treating inside the orbital rim with an Nd:YAG laser. They were wearing an external shield, not an internal stainless steel corneal shield. So, Matt, what are sort of the legal implications of this? And, how do you train? You have 2 fellows every year. You have tons of residents at Harvard going through. There's a lot of attending. How do you get consistency in eye protection at a big program like that?
Well, and I done this a few years ago. There was a laser safety course that's given that to people who use lasers within Mass General. But within our clinics, it's just by example, and I just beat into people that before any case starts, we all look at the goggles every time and check the wavelengths and what the degree of eye protection is. Same with the eye shields, and people do trip. People wear very long, thin heels. Rox had a great picture of one of our former fellows who was walking near a foot pedal, and she had these very fancy shoes that came out to a point that would have turned on the laser. I've tripped once, and the laser fired, and luckily the shields were in, so nothing happened. They were external, just hit the shield. So all of that can happen. I want to bring up one other point. Brian was talking about the Nd:YAG. To me, one of the truly and we were trained, this came from Rox, to be really careful with the Nd:YAG is, if you fire a 532, you're going to see a green flash of light. If you fire an Alexandrite laser, you're going to see a red flash of light. And there'll be that huge flash. If you fire a 1064 nanometer laser, as Brian will tell you, you're going to see nothing. The first time you're going to recognize that something's wrong, if you, it's not just the patients, the staff around you as well, you're going to know that there was a problem, is you're not going to be able to see. That's the end point. That's because you're not going to see the actual laser or the light flashing. You're going to know there's a problem when you start losing your vision. So particularly, they're all very important to be careful, but just remember there's no endpoint with the Nd:YAG.
So Susie, I remember being at a Maui Derm meeting and you talked about an experience as a fellow that happened when you had inadequate eye protection yourself.
Yes, and so actually I'm going to tie all this together because, and I'll tell you about the story, but the other thing with multiple lasers in a room, somebody can hit one foot pedal and fire a different laser, and that's actually happened, and luckily they only burned a hole in something, wasn't a person. So back to when you were talking about plume, when I was Rox's first fellow back in '91, we were doing the Q-switch lasers for tattoos. And when I was treating this one guy with a brand new tattoo, I went to go treat the tattoo, and a chunk of skin with tattoo in it landed onto my cheek. So I walked out and I said, Rox, we got to deal with this. This is probably, it's a Q-switch laser, so there's not enough heat in there to kill the virus. So we did a study and we proved that you do fluorescein diacetate, which is FDA, and the viable cells will stain green, and all the cells on this plastic acetate that I was treating through, because I wanted to contain this tissue splatter, were alive. So if you're treating tattoos, know that anything that's in those cells is still alive. Well, we were doing a training session and I had on goggles that protected for one wavelength and not the other. Basically, they protected for 532 because they were orange. And what happened, I gave the goggles that I personally was using all the time to a dignitary that was in the room. And then they gave me a different pair because I just happened to be closer. And the pair that they gave me only protected for 532. The 1064, you couldn't see that flash of light, but it bounced off because at the time we were still trying to figure out how to deal with all this tissue splatter from the tattoos. I was treating through plastic as a shield, kind of like a Vigilon type of thing. It reflected back into my eye. And I actually did feel the first pulse or two. I thought it was just kind of weird. And then I had a foveal injury. And basically, it's like a brownout. When you hit your fovea, you cannot see out of the middle part of your eye. Now, luckily for me, it was a teeny tiny spot. I healed up and it was fine, but it was a good 6 months of no fun for us. And some of these times you'll get a much bigger injury, and especially if you don't catch it right away, you could keep going. So, and this is, a long time ago, I should have checked the OD. There's an optical density on the goggles or glasses, and it tells you exactly how you need a OD of 6 or more in order for it to be safe. But you get caught up, and if it can happen to me, it can happen to anybody. And there's been multiple other cases. And then one other thing to Brian Biesman's point, when you have eye shields in the eye and you're treating within the orbital rim, it has to be a big enough eye shield, because I was an expert witness in a case where it was too little of an eye shield, so there was an eye injury because they just used it like an infant-size eye shield in an adult person, and that eye shield can move over to one side and still allow that light to get in there.
Great. So, when we do the internal shields, we have a few sized medium of those oculoplastique stainless steel shields where we do proparacaine drops and lots of lubricant anterior and posteriorly. But we also have some smalls because sometimes the mediums are really tough to get in and you have to use the overall small. So, Brian, do you have any advice for those circumstances?
I'm sorry, Joel?
Do you have any advice for those circumstances as far as putting in internal shields?
A couple of general things, yeah, for sure. First of all, the size is extremely important. Some people have shallow orbits or are nearsighted and have large eyes. You'll actually need to have a large size as well. So when the shield is actually in, you can palpate it through the lid and feel where it extends to the fornices, because you really want one that's going to give you protection up into the superior fornix near the orbital rim and down inferiorly. So that's a good way to know if you've got the right size. And I also love the oculoplastique shields, but other shields are very flat and they tend to move around in the middle of a case. So look at that. I love what you said about putting lubricant on the back of the shield. It does make people's vision a bit blurry, but if you irrigate it out with saline eye wash, or with it's actually sterile water eye wash, vision is just fine afterwards.